What I thought was, our HIT has been in sort of function for the last 2 years, so I'm going to focus my talk on what we have achieved in the last year. So in the last HIT conference, we sort of gave a bit more detailed review of some of these projects and the background to this. I won't go into the details of each of the projects. So these are the 3 projects we are currently working on: the teleclinic service for CKD and kidney transplant patients. We're doing sort of a safety project within NBT on acute kidney injury, and then we sort of established a study there for primary care staff on CKD. So the background to this, we, as I might have mentioned in one of the sessions, we sort of cover specialist renal services for a wide patch in the southwest. We cover up to Wiltshire, North Somerset, and a bit of Gloucester. So a lot of patients come to Bristol. We do outreach clinics for CKD patients in other hospitals, but a lot of transplant services is centralized in Bristol, and a lot of patients travel an hour or so for a 15 to 20 minute consultation. So we thought of this idea of providing telephone clinic, which would be much greener and might improve patient experience. And therefore we started looking into this about 2 years ago. We did an initial survey to see what the demand would be, and about 69% or 70% of the patients said they would take up the service if we were to offer this. So that's the background to this. And what we have done in the last year, since the previous HIT conference, is we set up a quality improvement workshop. So we've been working with AHSN, and we had a workshop with representation from all of that organizations, including NBT, and we also had some PPI input to the workshop. So we then process mapped the patient pathway as to how we think the service should run, and we sort of had a brainstorming session. So we did look into what are the things we might have to have in place before actually the service is delivered. So we developed some patient information sheet about what the service is about and what they can expect from the service. Then we also looked at who are the patients who are going to be suitable for this service. So we thought of choosing some quite stable transplant patients who are coming far away into Bristol. So we developed some patient eligibility criteria. So we did a bit of brainstorming session within the clinicians, and then we come up with some criteria. Then the major problem with us is, as a renal team, we rely heavily on blood tests, because we need to know how the kidney is working, and every time they come to clinic we do a blood test to monitor the kidney function. So if we are going to do a telephone clinic, what we need is for them to have had the blood test in advance of the telephone clinic appointment, and that has to happen locally in the local hospitals or in primary care. So we thought about how we're going to make that happen, and then we also thought about how we're going to book these patients into telephone clinic, which currently we don't provide within NBT. So we need to think about what sort of appointment letter goes out to patients, and what sort of instructions that need to be sent along with the appointment letter in terms of what blood tests they need in primary care, and what sort of blood pressure readings and other things they need to do before they actually have their telephone consult. So we did that back in November, December. We had a great sort of first 6 months when everyone was working very hard and trying to get this started. And then we had a sort of a dull period for the last 6 months. Mainly due to some of these challenges, some of which are quite frustrating, and some of them were unexpected. Say, for example, we had a new outpatient booking system which was implemented in NBT. We moved from Cerner to Lorenzo back in December. So that caused a huge problem for us, because the migration of data from the previous system to the current system did not happen as expected. So there were a lot of outstanding outpatient appointments that were missed, and people were lost to follow up. So we didn't want to sort of introduce a new service when the whole system was in a turmoil. So we had to sort of hold on to a project for a bit until this got resolved. So it's taken about 3-4 months for us to resolve this. So now we are back on track, and we're looking to sort of building up the service on our outpatient booking system. So the next thing, as I said, I mentioned previously in one of the sessions, was failure to engage CCG. So we have CKD population who are funded by the CCGs. We got kidney transplant patients who are funded by NHS England. We cover up to 6 to 7 CCGs, being a specialist renal service. So we have had some verbal confirmation from NHS England to say, yes, you can go ahead with the project. So we're going to get started with the kidney transplant patients, but we haven't been able to get that sort of agreement for the CKD population. We have had one verbal sort of agreement from South Gloss CCG, and we are still trying to engage the rest of the CCGs in the process. The main problem for us, as I mentioned before, was trying to get or organize blood tests in primary care, because as I said, we got 6 labs
people, say for example in North Somerset, can go to Taunton Hospital to get the blood test done, or they might go to GP where the blood tests go to Bath, or they might go to Yeovil Hospital. At the moment we don't have access to those results. So we need to find a way as to how these results reach us before the telephone clinic appointment, so that we can actually have a productive and efficient consultation at the time of the teleconsult. So we need to think about a way of how we can get this sorted out. So that's taken us some time to resolve. So where we are now is, as I said, we've got confirmation from NHS England to pilot this on transplant patients. So we're going to get started soon. We are currently building our template in our outpatient booking system is being tested now. So we are hopeful we'll get our first clinic going for kidney transplant patients come mid-July. What we have done is we are going to do a quality improvement project in support with AHSN. So we're going to do evaluation, as somebody pointed out. We started a service, but we failed to evaluate. So we're going to do a quality improvement project, and we have built in some evaluation measures around patient experience, patient outcome, and process measures. So we're going to do that over the next year to actually refine and find a model that best suits patient care. We have now developed a standard operating procedure for all 6 pathology labs in the region, going up to Taunton, Yeovil, Swindon, Salisbury. So the idea is, if somebody goes with a blood test request form to either of these hospitals, or if the GP send their blood test request to these hospitals, then the results directly come to us and don't go back to primary care. So we can access these results, and it will help us during the teleconsultation. With regards to the CKD patients, as I said, South Gloss has agreed to this, and what we are hoping is we might be able to negotiate this in their contract for the following financial year. So we're going to test this on transplant patients, prove that this works, and then roll it out to CKD patients, at least in the South Gloss CCG, and hopefully at some point we'll get the rest of the CCGs on board if we can prove this works. What we also have done in parallel is we are working with Clark West. We are developing a research grant proposal. So we are nearly finalized the grant proposal. What we are going to do is, once we have established the service, we are going to undertake an RCT comparing teleclinic and standard care. We, as I said, we are almost ready with the grant proposal. We're going to submit this to Health Foundation and RPBF grants next month, and to start this come to July 2017. So that's where we are with the teleclinic service. The next major project we are doing is on acute kidney injury. It's very common. 1 in 6 in hospital get acute kidney injury. So NBT signed up to reducing harm associated with acute kidney injury last year. So as part of that, we included this within our HIT work stream. And these are the several things we have done over the last year. It's been a busy year with regards to this particular project. What we have done is we have set up an e-alert within our laboratory system. What that means is, when a patient has a blood test, the system automatically compares your current kidney function against a previous kidney function test, and then if the patient's kidney function has got much worse than what it should be, then it triggers another e-alert or a report within the system. So what it then does is it alerts the clinician to say that this person could have possibly had acute kidney injury, and therefore we sort of can diagnose acute kidney injury early and institute appropriate management early. So that was done back in September 2015. We then also developed some patient information sheet around acute kidney injury for those who are at risk of acute kidney injury, for example, people with chronic kidney disease, people with diabetes, people with heart failure. So it is just to raise awareness around acute kidney injury amongst patients as to what they can do to prevent acute kidney injury. The major piece of work we did was around sequencing. So this revolves around providing a certain information in discharge summaries to primary care for those patients who have had acute kidney injury. So our sequence target for this, or the last financial year, was 80% in quarter 3 and 90% in quarter 4. We started quite low at 66% in quarter 1. So we did a lot of training and awareness sessions amongst junior doctors throughout the NBT, and we managed to achieve this sequence target for the last year. So we don't have any sequence for this year though. Other work we are doing around acute kidney injury is we are developing an e-learning module for nursing staff, which is nearly complete. So we are hopeful that we'll be able to roll it out within NBT over the next few months. AKI training has now become routine part of junior doctor induction. So they all get a session on AKI as to what they can do to prevent and how they manage AKI better. We are piloting a care bundle around AKI. For those who have had AKI, these are the X number of things you need to do to manage them better. It's not been greatly received, but we're hopeful we might be able to change culture and persuade people to use the care bundles over time. The main challenges we've had with regards to acute kidney injury, and the focus for us for the next year will be actually trying to capture the incidence data real time. What we don't know is whatever we are doing at the moment, whether it's having an impact on actually reducing the incidence of acute kidney injury or whether they're being managed better. So we are in discussion with senior managers within the organization to see how we can get IT support to capture this and actually produce this on a monthly basis, so clinicians and other staff within the organization can actually have a visual picture of how common this is and whether there is a trend towards decreasing incidence of AKI over the next year or 2 years. We are also continuing to work hard. What we hope in the next 2-3 years is people will start recognizing acute kidney injury as important as, say, for example, MRSA, C. diff, VTE preventions. A lot of work has been gone in the last few years about how we can prevent these things. At the moment, AKI is not at that level of importance. So what we are trying to do is try and engage people to get AKI to that level of importance in terms of how you deal with an MRSA infection, how you deal with a C. diff infection, and how you prevent VTE, for example, venous thromboembolism. So we are hopeful we'll be able to change culture and influence people over the next year or two. The main thing we need to do is what lessons we can learn from those who have had acute kidney injury. So we may have to undertake a bit more in-depth review of some of these cases by doing what we call as root cause analysis, and then identify areas where we can actually learn and find areas where we can improve and manage these patients better. So that will be the focus for us over the next year. And the final project we are working on is actually providing a study day for primary care staff on renal diseases. So we worked in collaboration with UWE, and fortunately they provided us free venue to do this half-a-day study day. So we are providing this at the moment free of cost. So it's mainly intended for primary care nursing staff. We started our first study day, which is a half-a-day study day, which I do with my registrars. We did that first in February, and then we had a second one in May. And the feedback was very positive. 98% said they would recommend this to others, and we did a proper evaluation of the study day, including a pre and a post quiz study day. So we did all of that. I haven't shown all of that data here, but as I said, very positive response, and we're going to carry on doing this. We have 2 more study days booked for August and October, and they're fully booked so far. So those are the 3 main projects we've been working on. And these are the members of the HIT team and some of the collaborators. Lots of energy, lots of volunteer time contributed to this work, and none of them are paid for any of the HIT work except me. As I said, we got PPI input, we got wide collaboration, and thanks to all the team members. Thank you.